Hi, I'm Dick Moberg, your host for today's presentation. I want to welcome you back to the Brain Matters webinar series. We took some time off late last year and early this year to complete a merger with Micromed, Europe's leading EEG and epilepsy company. We're now back on track with some exciting webinars lined up for this year. The past 3 weeks have been challenging for all of us. Where we thought we had leadership, we didn't, but it emerged in many places, some expected, some not. When this is all over, I'm sure we will have new perspectives on our global community, on government, on healthcare, and on our fellow travelers on this planet. Most of you listening in are in the healthcare field. On behalf of my company, I want to thank you for what you're doing. Our future is clearly in your hands. We're going to dispense with our normal introductory material since most of the meetings we would promote have been canceled. And we're going to go right into our featured speaker, Dr. Arti Sarwal. Dr. Sarwal is internationally known in the field of ultrasound and neurocritical care. She's the head of neurocritical care at Wake Forest School of Medicine in beautiful Winston-Salem, North Carolina. We'll present a recorded presentation followed by a live Q&A period with Dr. Sarwal. So please type in your questions during the talk. We will now play the presentation.
Hi, everybody. Thanks for joining in. Today, I'll be presenting my take on emerging applications of NeuroUltrasound in the ICU. My name is Arti Sarwal. I am a neurologist and a neurointensivist at Wake Forest School of Medicine in Winston-Salem, North Carolina. I have no relevant financial disclosures. The two inherent biases I always discuss as a part of my talk are presented here. One, I'll let you read it. And the second, most of the work that I'm presenting here has been built on extensive work done by others. And I am the new kid on the block in NeuroUltrasound. This presentation is inherently my take on how I have interpreted that work and how I use on a day-to-day basis in taking care of my patients. If you're familiar with the history of ultrasound, the very original point of care neuroimaging was something we call as echoencephalography, which was an application of ultrasound based on sonar technology to look for midline shift and position of the lateral ventricles to diagnose focal lesions in the brain way back in 60s. It was the go-to mode for neuroimaging until CT scan took over in 1971. And if you remember any of your both Star Trek and Star Wars movies, there was almost a predictive description of using point-of-care neuroultrasound. And circa 2020, currently we are using neuroultrasound with different levels of confidence in both neuro ICUs as well as medical, surgical, cardiothoracic, and trauma ICUs in different applications ranging from detection of hydrocephalus, incidental discovery of subdural hemorrhages and ICHs in hemicraniectomized patients, to evaluation of brain death, vasospasm in aneurysmal subarachnoid hemorrhage. And emerging applications have even taken neuroultrasound to diseases like hepatic encephalopathy, managing hemodynamics in post-cardiac arrest syndrome, as well as pediatric population and patients with sepsis to evaluate for hemodynamic changes associated with septic encephalopathy. A recent review by a collaborative group of authors sums up very nicely the applications of brain ultrasound, both from a quantitative perspective as well as a qualitative perspective in the different diseases in both neuro as well as non-neuro ICUs. Today, we'll focus on three big segments of assessment that can be performed using a neuroultrasound. The cerebral edema assessment that basically rests on traditional markers like assessment of pupillary reflexes, optic nerve sheath assessment as a marker of papilledema, midline shift using neuroultrasound. People have described both ICH, subdural hemorrhages, and epidural assessment using cranial ultrasound. The reason I highlighted it differently is I do not think that it will replace CT scans based on the current technology, but we will mention it if they're incidentally discovered during your assessment of cranial ultrasound for other modalities. On the blood flow side, we will focus on cerebral hemodynamic assessment with use of NeuroUltrasound as a surrogate for intracranial pressure or cerebral perfusion pressure, both for ruling in extremes of high ICP as well as ruling out ICP crisis in a patient who otherwise cannot get traditional neuroimaging modalities. I will share with you a case study for both hyperperfusion and hypoperfusion states where cerebral hemodynamic assessment using ultrasound can be useful. The traditional modalities of sonographic assessment for aneurysmal subarachnoid causing vasospasm and brain death assessment are very well laid and will not be discussed in this talk. I still struggle with using ultrasound for hydrocephalus assessment. We will talk about it based on what literature has described so far, but I again do not feel that that's something I have myself been able to reliably reproduce in my practice to have CT scan be replaced by ultrasound measurements. So first we'll start with ocular ultrasound, which is basically a ultrasound-based modality to replace our pupillary assessments and papilledema assessments. Ocular ultrasound needs to be done at a preset that allows ultrasound to image eyes at a very low mechanical index and thermal index. So please ensure that an orbital preset with low power is used for these assessments. You can talk to your local vendors to have these settings or look for orbital ultrasound presets. The transverse view of ocular ultrasound is based on visualization of the anterior chamber and the posterior chamber with your pupillary assessments very nicely marked here with the blue marker can be seen, and the consensual pupillary reflex can be used as a basis of testing your pupils. It usually does not need to replace clinical assessment when the pupils are accessible, but in patients who have significant orbital edema because of an injury without obvious globe rupture, or patients post-craniotomy where the subgaleal edema impairs eye opening, this can be a useful marker when the clinical pupillary assessments are impaired. You can also do a coronal view in which the probe marker is pointed downwards to cut across the iris at a horizontal angle. And using M mode, you can also look for pupillary reactivity in a quantitative fashion. Optic nerve sheath has been described pretty extensively with variable interest and reliability in both post-concussive syndromes outpatient, as well as detecting intracranial pressure surrogate in the ICU population. Qualitatively, when you look at the globe, optic nerve sheath can be seen posteriorly. Optic nerve sheath itself is measured quantitatively about 3 millimeters behind the retina, and the sheath diameter, which is the optic nerve itself, plus the surrounding CSF, can be measured horizontally with most standardization measurements obtainable 3 millimeters behind the retina. The caveat to that is the inter-rater reliability and the variance in technique. To catch a true transverse view, you have to ensure that the optic nerve is visible throughout the length of your imaging for optic nerve sheath diameter measurements. And this variability is what produces a lot of difference cutoffs in the various studies that have reported optic nerve sheath diameter. Qualitatively, looking at the optic nerve sheath, you can see the sonographic surrogate of papilledema, or what we call as optic nerve bulging into the posterior chamber, called a Crescent sign. The presence of a Crescent sign is very sensitive to denote that the patient has had an ICP crisis or has a supraphysiological ICPs. The exact response to therapy or linear changes with ICPs have not been described discretely. If you are going to be using optic nerve sheath diameters in your regular practice as a surrogate for ICPs, the standardization of the technique to make sure there is decreased variance in reproducing your measurements is extremely important. And the cutoffs for your own technique need to be created by repeated measurements. The literature itself has described variable cutoffs anywhere from 4.8 to 6 millimeter, with the pooled area showing decent diagnostic, but not perfect accuracy when correlated to ICP. So knowing the caveats of standardized technique and finding the cutoffs for your own technique is key to using optic nerve sheath as a surrogate for increased ICPs. Cranial B-mode ultrasound itself has some emerging applications. Your skull has a few thin areas in the temple, and this forms what we call as the temporal window, where a low-frequency probe with the marker pointed towards your eyes can be used to image the brain across the basal cistern. On the B mode, you will see the opposite part of the skull and the midbrain in the center. That's where the butterflies in the brain comes from, with peduncles visible in the front and colliculi visible in the back. Anterior, by convention, is always towards the left side of the screen, posterior towards the right side of the screen. On the proximal part close to the probe, you can see the ipsilateral bony landmarks of the sphenoid wing and the petrous part of the temporal bone, showing the opposite skull clearly visible and having the butterfly visible, representing the cross-section of your midbrain, is a good sign that the patient has temporal windows to allow further visualization of structures. 10 to 35% of normal population, depending on the race, age, and ethnicity, may not have temporal windows. Some patients may have temporal windows on one side, but not on the other side. So scanning both the temporal windows before claiming that the patient does not have temporal windows is extremely important if this is going to be your modality for assessing patients. The correlation of anatomical structures and the visualization of the anatomic structures depends on the temporal window. In a patient who has a hemicraniectomy, so the whole skull is visible as a ultrasound window, the falx cerebri, the mammillary bodies, peduncles, as well as the colliculi, including ipsilateral ICH with vasogenic edema, is pretty clearly visible. On different planes, you can see the lateral ventricles, the posterior horns with calcified choroid plexus, as well as the splenium of the corpus callosum. New structures like intracranial hemorrhage, vasogenic edema have shown very nice correlation. This is a B mode of the ultrasound, and this is your corresponding CT scan in a patient who has a hemicraniectomy and full access to the brain windows. The details in patients without hemicraniectomy, full skulls, are obviously less delineated and depend from person to person. It is possible to measure midline shift in a patient, even without a hemicraniectomy, looking for a significant marker of midline, whichever is better visible, either the falx cerebri or the third ventricle, and measuring it from side to side, preferably from the same temporal windows, to look for midline shift. This technique has shown decent correlations with CT scan measurements of midline shift if standardized protocols for measuring midline shift are followed. The Brain Trauma Foundation guidelines mention the midline shift as the deviation of the septum pellucidum, with half of the interparietal diameter divided by the difference between the biparietal diameter and the distance of the septum pellucidum from one side of the skull. In ultrasound, it is extremely important to distinguish the plane, whether you are measuring the midline shift at the ventricular plane and hence using septum pellucidum, or you're using the third ventricular plane, or you're using the midbrain plane and the midline shift to make sure that reproducible midline shift can be measured. Serial measurements are more helpful than incidental one-time measurements. Hydrocephalus is another application where people have looked at third ventricular diameter as measured on the ultrasound to look for hydrocephalus. Again, it depends whether your patient's disease pathology has third ventricular enlargement. Correlations with CT scans have been statistically significant, but a very robust standardized protocol of measuring it and reproducing it by the exact same protocol with standardized angle at which you're insulating the base of the brain is extremely important to reproduce this. Again, I personally myself have not found it useful for my practice to replace this for a CT scan, but this is something that definitely can be done if your patient is unable to go for a CT scan or patient's third ventricular measurements are at extremes. The most useful I find in my practice is cerebral hemodynamic assessment, using NeuroUltrasound and using it as a surrogate for both intracranial pressure as well as assessing cerebral perfusion pressure of the patient. One emphasis of using NeuroUltrasound as a non-invasive ICP marker or a meter has been an application of orbital ultrasound. This is based on a 2-depth Doppler ultrasound where orbital presets are used for changes in pressure exerted on the orbit to normalize extracranial and intracranial part of IC assessments using orbital ultrasound. The challenge for this is the technique itself, accessibility to eyes, definite use of preset and low power, and third is safety of oculocardiac changes that can occur in patients with increased ICPs when this maneuver is attempted. People have looked at clinical assessments, ICP monitors in assessing goal-directed therapies for cerebral edema. We have found that our current clinical markers like pupillary dilatation, Glasgow Coma Scale, our physical assessments are limited with imperfect sensitivity and specificity to detect changes in ICP. So having a ICP monitor definitely helps you in therapy, but not every patient can get an invasive monitor. Some of our patients are limited by anticoagulation or their disease sickness or underlying coagulopathy that impairs ICP monitors. The patient's inherent disease, whether it's compartmentalized versus non-compartmentalized ICP crisis, also dictates whether your ICP monitor will show linear and sensitive changes to help you target therapy in that patient. So in patients where a non-invasive surrogate of ICP can be helpful because an invasive ICP monitor cannot be inserted. For example, patients with cerebral venous sinus thrombosis, where venous infarcts can cause cerebral edema, but at the same time, therapeutic anticoagulation impairs your ability to monitor these patients' intracranial pressures. Thrombocytopenia or coagulopathy related to higher grades of hepatic encephalopathy in managing edema, especially for patients that are liver transplant candidates, or patients that have neurological complications but have underlying thrombocytopenia from a chemotherapeutic agents, and monitoring patients in these, monitoring neurological status in these, or ICP surrogates in these using NeuroUltrasound can be extremely helpful. Another subset of patients where NeuroUltrasound can be a surrogate for CPP assessments in patients that are difficult to transport. If the patient has extremely high ventilator settings or settings similar to high-frequency oscillator in pediatric populations, where patients cannot be transported on a transport vent. Patients that have very high need of vasopressors with systemic hemodynamic instability, patients on ECMO, patients with intra-aortic balloon pumps or continuous renal replacement therapy, where imaging is feasible but extremely difficult and portends risk both for the patient's providers as well as the patient's own safety, where having a bedside surrogate for CPPs and ICPs in ruling out extremes of cerebral edema or giving a supportive evidence that the patient's CPPs are not impaired significantly enough to shift the focus on neurological prognostication can be extremely helpful. For qualitative assessment, B mode of the ultrasound added with color Doppler can be useful as well. This is your base of the brain with midbrain, opposite skull, and the circle of Willis visible in one plane. Your MCAs, ACAs, PCA, and opposite vessels on the other side. You can use non-imaging Doppler as well, where the Power M mode Doppler can be used to identify the depth and the direction of the vessel and insonate and create a pulse Doppler waveform. Whether you use a pulse Doppler waveform created by an imaging mode Doppler or a non-imaging mode Doppler does not matter. The following description basically would be on the waveform analysis, irrespective of imaging or non-imaging Doppler. All of us are familiar with the shape of the cerebral hemodynamic waveforms. Your systole is represented by the first third of the cardiac cycle, diastole by the later 2/3 of the cardiac cycle. The systolic upstroke is typically extremely sharp with a stepwise deceleration in cerebral waveforms. The diastolic flow typically represents a third to half of the systolic flow, and at no point in the cardiac cycle is the flow velocity anywhere close to zero. So this is typically a cerebral hemodynamic waveform or a low resistance circulation. The metric that we commonly use quantitatively to look for imaging parameters of ultrasound pathology is the mean flow velocity, though both the peak and the end diastolic velocity are measurable. We also use an index called the Pulsatility index, which is calculated by subtracting the peak and the end diastolic velocity divided by the mean. And this PI represents distal resistance in the brain. It's a sensitive marker to denote increased distal resistance when high, although it is not specific to pathology. So when you have increased distal resistance, your PIs would be significantly higher than 1.2, and this could be because of intracranial pressure, distal atherosclerosis, advanced age, or we can see physiologically normal PIs in posterior fossa. Very low PIs can be seen in AV fistulas or places where dysautoregulation is causing significant cerebral vasodilatation, and these will be significantly less than 0.6. Looking qualitatively at these waveforms, we are familiar with the transition of the waveforms across a degree of stenosis. So if this was a focal stenosis in a cerebral vessel, your normal cerebral waveforms with rapid upstroke, stepwise deacceleration, and a robust diastole are transformed to resistive waveforms where the rapid upstroke, more rapid deacceleration with the diastolic significantly less than a third of the systole represent the focal part where there is stenosis or increased resistance. If this resistance compromises hemodynamic flow, your systolic downstroke touches the baseline, diastole is significantly compromised, and when insonated beyond the area of focal stenosis, you can see these blunted waveforms, which also are called parvus et tardus, delayed upstroke, delayed downstroke. So if you insonate from proximal to distal part of stenosis, your waveforms will transition from resistive waveforms to post-stenotic waveforms. We also are aware that extracranial waveforms are high resistance and intracranial waveforms are low resistance. Using these, we have seen serial changes in the qualitative nature of these waveforms as ICP elevate in the brain because of a compartmentalized model enclosed by the skull. So your normal arterial waveform, where the ICP is significantly lower than your diastolic blood pressure, will be a normal cerebral low resistance waveform. Progresses to a high resistance waveform because of increased distal resistance created by high ICPs. So this waveform typically will have lower diastolics compared to the systolic and resistive systolic waveforms, and quantitatively can be looked at by high PIs. If your ICP considerably elevates in relation to your diastolic blood pressure, the forward blood flow delivered during the systole, which does manifest itself as a sharp upstroke and a sharp downstroke because of the increased resistance. During diastole, the increased ICP greater than the diastole will cause a reversal of the flow. So patient has forward flow during systole, but reverse flow during diastole. This is typically called an oscillating waveform, and if allowed to persist, with a big if allowed to persist, this is incompatible with life. If the pathology underlying increase in ICP progresses unchecked, eventually the diastolic flow gets obliterated and only systolic spikes or systolic humps can be visualized. These waveforms are incompatible with cerebral perfusion in that particular vessel. Eventually the patient progresses to cerebral circulatory arrest. Seeing these waveforms in a linear fashion can tell you progression of ICPs over time. And these also can manifest when you're escalating osmotic therapy or decompression surgically, and can show response to therapy. So as a point of care manifestation, if you perform transcranial Dopplers on a patient with a focal stroke on one side and cerebral edema suspected, and you're assessing circulation on the opposite side, and the opposite side shows oscillating waveforms like these with forward flow during systole, and reverse flow during diastole, you know that the patient's ICPs are significantly elevated compared to their diastolic blood pressure at the ears. So these by itself will tell you that the patient is very high risk of progressing to cerebral circulatory arrest and has malignant cerebral edema at this point. You can also see this qualitatively in the color Doppler. Here you can see the color Doppler signals persisting throughout the systole and diastole. And on this picture, you can see you have significant flow during systole, but complete obliteration of flow during diastole. So if your technique is proper, this can be a qualitative signal to you that this patient's pulse Doppler may show impaired diastolic flow. This is also a great way to rule out malignant cerebral edema, say in a patient with ECMO. This is a patient with VA ECMO, so has non-pulsatile waveforms. Although you may not manifest the peak systolic and the end diastolic part of a waveform, the persistent horizontal waveform represents the mean flow going through the brain. And in this case, the mean flow going through the brain is about 60 centimeters per second, which is pretty decent cerebral flow through a patient with ECMO. This itself may not tell you much about patient's focal pathology, but this gives you a significant marker that the patient's CPP is not impaired, and this patient does not need neuroprognostication as the focus of therapy at this point, and could be the only modality that gives you that information in the lack of a CT scan. So when qualitatively assessing patients for serial changes in waveforms for increased ICP, we see two distinct patterns. This is your normal cerebral waveform progressing to resistive waveforms where sharp systolic upstroke, systolic downstroke, touching to baseline, and impaired diastole, much less than a third of the systolic flow, going on to oscillating waveforms in the late half of the systole. These will progress to complete oscillations during diastole, followed by systolic humps. People have used this linear change on a continuous monitoring model, and there are extensive published data on seeing these waveforms transition from the low resistance waveforms to the high resistance waveforms that you see when ICPs are increased. It also makes physiological sense to look at the amplitude of these waves as a quantitative marker that denotes where in the curve of compensated versus decompensated cerebral perfusion is the patient. Your waveforms will be low amplitude with low difference between the peak and the end diastolics when you have physiological CPPs, but when your CPPs are impaired or ICPs are supraphysiologically elevated, you will see resistive waveforms. The second pattern that is sometimes visible is what we call as the Wind-Kessel effect, or the phenomena of non-compliance seen in patients who have recently seen an increase in ICP. Your normal cerebral waveform, a manifestation of your systemic arterial waveform bouncing against the skull, represents a systolic upstroke and two notches in the systolic downstroke called P1, P2, P3 in the ICP literature. When your brain becomes non-compliant, the P2 itself, the second notch, can be equivalent to the systolic notch or sometimes even higher than P1. This by itself represents a non-compliant brain. There are concerns about brain resistance versus brain elastance being manifest as compliance, but in a physiological manner, what I take it to mean is that this is the kind of patient that has a non-compliant brain edema and is unlikely to maintain cerebral perfusion pressure at smaller elevations of ICP or lower ICP values than 20 or your usual thresholds, and needs to be monitored more closely. People have described this phenomenon in ICP literature. If you're familiar with Lundberg waves, patients with non-normal compliance in the brain manifest P1, P2, P3 that are in a descending order in the systolic downstroke. Once the patient experiences a plateau wave or elevations of ICP for some time, ranging from 5 minutes to 60 minutes, this may change the compliance of the brain, while the baseline ICP itself may not come back to the pre-ICP elevation values, change in the compliance of the brain with P2 being higher than P1 now portends decompensation at lower elevations of ICP in these patients. People have also used the word vent castle effect to notify this phenomena in hepatic encephalopathy patients, where these variable patterns of P2 relation with P1 can show non-invasive markers of ICP elevations in a liver failure patient that otherwise may not have an ICP monitor due to coagulopathy or thrombocytopenia. So the second pattern itself, if followed linearly, can be a marker that this patient has seen an ICP elevation in the recent past and trigger closer monitoring of this patient for waveforms that could portend high ICPs. So when I serially monitor these patients, where I cannot have an invasive ICP monitor or the clinical exam is confounded, I watch out for both these patterns, the simple pattern being the waveforms changing from low resistance to high resistance circulation, especially if there is a reversal of flow at any point of the cardiac cycle, and use that to escalate my therapy, which could be osmotic therapy, which could be triggering early surgical decompression. In some patients, if I do serially catch the Windkessel effect or a non-compliant transition to these waveforms, these are the ones that I trigger for closer monitoring. Again, escalation of osmotic therapy or earlier triggers for surgical decompression if the patient otherwise is a surgical candidate. These patients may also progress to the same resistive waveforms, but possibly at a lower threshold or with lower ICP elevations compared to regular patients. There has been interest in venous ultrasound in the brain to look for ICP markers. There has been variable studies which have looked at straight sinus velocities with the presumption that straight sinus velocities may be elevated beyond normal as a marker for increased ICPs. While venous ultrasound requires much lower filters and is technically a little more challenging than arterial ultrasound, I use it more often to rule out malignant ICP elevations. So you can ultrasound pretty much every venous sinus and vein in the brain. This is your transverse venous sinus measurements, your middle cerebral veins measurements, and the most common one that you will find out is the deep veins, basilar vein of Rosenthal, which can be insulated along with the PCA. I use PCA insonation and venous ultrasound insonation of the basilar vein of Rosenthal when present as a marker of absence of uncal herniation more often than quantitative markers itself. So if my patient has a pathology that looks like will predispose them to uncal herniation, and I am doubtful on the CT scan or a CT scan cannot be obtained, if I get robust PCA waveforms, which are low resistance, and beautiful cerebral venous waveforms insulated along with the PCA, that gives me a marker that this patient's both vessels, arterial and venous, are not impaired by uncal herniation. It needs to be validated in larger studies and with other markers of invasive parameters, but this is preliminary how I'm using venous ultrasound. Quantitative assessment has seen extensive interest, mostly for linear serial measurements of ICPs, and extensive work has been done by others in this field by using continuous monitoring with Transcranial Doppler along with other invasive measures. This is a graph from the Cambridge group that shows a very beautiful correlation of PIs in a global TBI model where the elevation in the PIs, drop in flow velocities, corresponds with decreased CPPs. There are caveats of CPP ranges in which this model stays linear. The relationship of PIs to CPPs also changes, whether you have a compartmentalized versus non-compartmentalized cause of increased ICPs, but can be extremely useful marker if this is the only modality you have to measure on a linear basis. There have been formulas proposed to measure non-invasive ICP using the PIs, and this is the formula that was most validated. Unfortunately, multiple efforts at reproducing this formula in other populations has not reproduced as robust results. And this formula seems to be valid in a very specific range of CPPs when the patient is normothermic and normocarbic, which always may not be possible. Multiple attempts have been made to look for flow velocities obtained from transcranial Dopplers, to look for non-invasive ICP measurements as well as CPP measurements. People have looked at critical care closing pressure that seems to have some emerging promise in being a good surrogate for non-invasive ICP measurements. The challenge behind having these reproduced in your ICU is infrastructure. You need a robust non-invasive continuous monitoring platform, which is able to monitor the patients for up to an hour on a serial basis. Patients' hemodynamic parameters and systemic parameters that increase ICP have to be standardized. The frequency at which the measurements are input into the softwares that help you calculate these on a linear basis needs to be standardized. And the sensitivity of these changes, whether you're measuring parameters every 10 seconds versus every 2 minutes. And the kind of infrastructure required may not be feasible for all centers to practically use this on a daily basis. The black box model has also shown significant promise. Again, if your infrastructure allows and you have local expertise to implement these, there is plenty of literature that is very promising in global TBA model for use of NeuroUltrasound markers to calculate ICPs non-invasively. Most of these have shown nice correlations to be practically useful. These two graphs came from the Cambridge group and represent the correlations of different ways of measuring non-invasive ICPs in a model that had persistent ICP elevation versus a model that had transient ICP elevations on different time points and have shown decent sensitivity in measuring ICPs. Another part where I find NeuroUltrasound an important marker is hyper and hypoperfusion states. So all of us are familiar with increased velocities as being a marker of vasospasm in subarachnoid hemorrhage. But if you look at the qualitative assessment of these waveforms and the PIs, this is typically what we call as a velocity with values way higher than normal. Normal MCA velocities are less than 80. In this waveform, you have very high velocities in the range of severe vasospasm, but the PIs are normal. And this could be a patient that has either hyperemia or vasospasm causing ICP elevations. By itself may not help you distinguish one versus the other, but when followed serially and when taken into the context of patients' pathology and markers, can help you distinguish hyperperfusion states. Looking at this waveform, this also represents very high velocities, 188, in the range of severe vasospasm. But if you look at the PIs, they're extremely low. So the diastole is pretty robust compared to the systole. Normal values of PI are 0.6 to 1.2, and here the levels are 0.4. So this gives me an indication that this patient is either having collateralization-induced hyperemia that is causing decreased distal resistance, and that's why the velocities are elevated, or this patient is hypercarbic, causing cerebral vasodilatation that could explain these waveforms and these numbers, or this patient is having hyperperfusion state in which velocities are elevated because of systemic hypertension in settings of impaired autoregulation, and the systemic vasodilatation caused by impaired autoregulation is manifest as low PIs. So again, one snapshot may not give you a very specific information, but when taken into clinical context, confounders having been addressed and serial measurements done, these can help you distinguish a patient with hyperperfusion. We have seen patients post-cardiac arrest where the waveforms represent impaired autoregulation and direct correlation with systemic hypertension. And when patients' blood pressures are normalized, the high velocities as well as the PIs resolve and get normalized as well. And this could be one of the ultrasound markers of concerns for hyperperfusion-induced injury in post-cardiac arrest syndrome. We've incidentally also found areas of focal stenosis in patients post-angiogram, patients with aneurysm coiling that are being monitored for vasospasm, where this patient had mid-M1 velocities of 173 with normal PIs representing vasospasm and being treated for vasospasm, and was incidentally found to have from resistive to post-stenotic waveforms in the distal part of the MCA. So this tells you that the patient developed a focal stenosis between the mid-M1 and the distal M1 with resistive waveforms, sharp upstroke, rapid but stepwise deacceleration with high velocities, a phenomenon called eliasing, and when insulated distally, had post-stenotic waveforms, slow upstroke, slow downstroke, robust diastole, with low PIs manifesting, and patient CT angiogram confirmed that the patient had a focal stenosis between the two from an embolus caused by one of the disrupted coils. As a final part of this presentation, I'll describe 3 case studies where I feel emerging application of NeuroUltrasound and using it to understand patients' physiology can have significant promise and become a very handy tool to add to your armamentarium of hemodynamic assessment by bedside. One of these case studies is a published study that I hope to reproduce in real life. This is a study of a subarachnoid hemorrhage with CT scan markers of subarachnoid hemorrhage, but no malignant cerebral edema in a patient with high-grade aneurysmal subarachnoid, and patient's waveform transitioned from normal waveforms to very resistive waveforms, systolic upstroke, sharp downstroke with impaired diastole, with oscillating waveforms, traditionally considered incompatible with life. There was a significant augmentation of osmotic therapy, and these waveforms returned to normal, and the patient went on to do relatively well for what could have been the outcome if this was considered irreversible. So hemodynamic assessment using NeuroUltrasound can be your trigger for escalating osmotic therapy or surgical decompression when you see these waveforms transition. This is an example of ruling out malignant cerebral edema in a patient that we used in a pediatric kid that was intubated for H. influenzae associated acute respiratory distress syndrome requiring VV ECMO. Patient suffered an intracranial hemorrhage and could not be continued on VA ECMO because of inability to anticoagulate and was transitioned to high flow oscillator. Because of the dynamics of the high flow oscillator, which can be seen here, patient's EVD that was inserted prior to us assessing the patient was not functional and was not able to give reliable waveforms to help discern osmotic therapy escalation. Because of high flow frequency oscillator, patient was unable to get a CT scan. The concern between providing teams was follow-up on the ICH to assess whether the patient had significant progression of ICH or impaired cerebral edema that would mandate goals of care based on some additional logistics of the case. So we used ultrasound in this case first to assess the feasibility that hemodynamic waveforms could be assessed despite the high frequency oscillator. So you can see there were times when we were unable to assess the waveforms, but in between the oscillations, we were able to get pretty decent arterial waveforms, both ipsilateral as well as contralateral to the patient's ICH, as well as the venous waveforms. In that particular patient, the location of ICH portended an uncal herniation pathology, and showing normal MCA waveforms on both sides within the normative values for patient's age, as well as intact cerebral venous waveforms, both in the middle cerebral venous system, as well as in the deep cerebral veins, gave us a marker that this patient has not suffered additional neurological insult and does not have extremes of ICP elevation impairing CPPs. We continued care in this patient to the point of weaning high flow oscillator, and follow-up CT scan confirmed with our findings. So this gave us a marker to continue aggressive therapy and not let neurological prognostication impair systemic care in a patient who had high risk for systemic as well as cerebral dysregulation. This is another case study of a patient where patient had intracranial hemorrhage on one side, and on the ipsilateral side, the compression of ipsilateral MCA, both from increased ICP elevation and the resistive effect of the ICH caused resistive waveforms, and the opposite cerebral hemisphere when insonated showed non-compliant waveforms as manifest by P2 more than P1. So this is a patient that probably has impaired CPPs on the side of the ICH, and this adjustment or non-compliant waveforms on the opposite side, and is tethering at a point of cerebral herniation. Patient's optic nerve sheath at that point was 6.4 millimeters, so above the thresholds for normative for my practice. And these three markers gave us a trigger that this patient needs escalation of therapy. We used both medical therapy escalation as well as triggering therapy by surgical intervention using minimally invasive surgical evacuation for the ICH. And post-evacuation, patient had restoration of waveforms, which continue to be resistive, but much more indicative of better cerebral perfusion compared to the prior. So this is pre-intervention ipsilateral to the waveform, post-intervention ipsilateral to the waveform. And the venous ultrasound also showed intact venous waveforms portending no uncal herniation in this case. The last case is a post-stroke management for hemodynamic assessment. This is a patient that came during the winter season at a very busy time of the year with mechanical thrombectomy for acute right ICS stroke with complete recanalization and a focal lesion of the ipsilateral ICA with less than 50% focal stenosis that was to be intervened after the acute phase by a stenting. This patient came with a stroke scale of 16 to 17 with left hemiparesis and neglect, and received an MRI at the time the patient was still asymptomatic. Received an MRI at the point that the patient was still significantly symptomatic with a stroke scale of 17 within hours of getting the mechanical thrombectomy. Strangely, the MRI was absolutely normal with no restricted diffusion. Now, although in anterior circulation, the positivity of DWI is not 100%, but to have a patient with hemispheric syndromes, a stroke scale of 16 to 17 with a negative MRI left us a little confused. We performed a bedside assessment on this patient while he was still symptomatic, and then changed some parameters, which I will show you. So at 10:17 in the morning, patient's MCA on the opposite side, the normal side, had velocities of 75 with normal cerebral waveforms, but the ipsilateral MCA, which was completely decanalized on the angiogram, had velocities of 28. We assumed that this patient had a hemodynamic flow limiting lesion of the ipsilateral ICA that was seen on the angiogram, though not significant enough for more than 50% stenosis at that time. Patient might have been collateralization dependent. And we assumed that dropping the patient's blood pressure to normal blood pressures, which is standard of care for post-recanalization TICI 3 for our center, we could have caused this patient's collateralization to fail to perfuse its lateral brain. So at 10 in the morning, patient had 70s velocities on the opposite side, but 20s on the ipsilateral side. By raising the patient's blood pressure back to 160s from the previous 140s, the ipsilateral MCA velocity improved, and so did patient symptoms. And we used TCDs to have a graded increase in the patient's blood pressure because we were also worried about cerebral hyperperfusion injury, and used the normalization of the ipsilateral MCA velocities to find a blood pressure target where the patient was able to maintain MCA perfusion. So from 75, the opposite MCA increased to 77, but by raising the blood pressure from 140 to 160, the ipsilateral MCA symptomatic increased from 28 to 54, and this corresponded to significant resolution of symptoms, and the patient was discharged home with absolutely normal neurological exam with plans for stenting of the proximal ICS stenosis in the immediate post-op period. So this is my take on using neuroultrasound parameters as a goal-directed therapy for multitude of cases ranging from post-stroke management to ICH evacuation to patients that cannot get traditional neuroimaging. People have published parameters using optic nerve sheath TCD parameters as well, and I will encourage you to explore this in your practice. So to sum it up, my take on emerging applications of neuroultrasound ranges from using TCD as a surrogate for the assessment of cerebral edema markers, where pupil assessment, midline shift assessment, or optic nerve sheath assessment can help me. In a hemicraniectomy patients, say on anticoagulation, I use it if I incidentally find the epidural, subdural, or ischemic stroke. In patients who cannot get traditional neuroimaging, like a patient on high ventilator settings, high-dose vasopressors, ECMO, HFO, or balloon pump, I use this as a marker to rule out extremes of cerebral edema and extremes of ICPs. And in patients who cannot get traditional invasive neuromonitoring but need one to titrate therapy, I use this as an index of cerebral perfusion pressure whenever feasible, keeping the caveat that systemic markers of hypercarbia, autoregulation need to be assessed, and serial measurements in the patients are more helpful than absolute one-spot measurements, especially when using it as an assessment of cerebral perfusion pressure. Happy to take any questions. Thank you.
Artie, thank you so much for an amazing presentation. And to our listeners, now is the time to send in any questions you have. And I'd like to just take a few minutes before questions to talk to you about a few things. So first of all, a reminder about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. And I'm excited to announce our next webinar with Brandon Westover and Zahar Zafar from MGH, talking about big data and AI applications in EEG. And you can register for this webinar on our website. I'd also like to tell you about my podcast, Dick Moberg's Neural Network. I've been in this field for 40 years and thought it would be good to tell the stories of those who helped shape the field of neurocritical care, basically a lot of my friends. And I hope you find it interesting. So please join it. So once again, please send in your questions, and we'll now go live to Dr. Sarwal in Winston-Salem for our Q&A session.
Hi there, can everybody hear me?
We can hear you. I think other people should be able to as well.
Awesome. Well, thank you so much for joining us. I know it's a crazy time and everybody is stretched thin with all the preparedness, so we really appreciate everybody joining. So I was asked cranial ultrasound risks in hemicrany patients. So I think one big risk is obviously the amount of pressure that you exert, and that needs to be very carefully thought through when you are scanning these patients. These patients do have a soft, unprotected skull, but knowing the precautions that we take, we haven't had any adverse events ourselves, but we need to be cognizant of the pressure we exert on the skull when we scan them. Typical teaching is that the amount of pressure you are putting on the ultrasound probe should be the same as you're scanning on the top of water with a very luxurious amount of gel, and you don't want the water to ripple. So luxurious amount of gel and minimal pressure is the key to scanning a hemicrany patient. Another person has asked me application in newborns. So I personally do not perform ultrasound in newborns. There are two approaches of doing that. One is through their open fontanella to look for intraventricular hemorrhage and parenchymal lesions. That's a pretty well-established literature out there. Unfortunately, that's not my area of expertise. We do on a regular basis perform transcranial Dopplers for the same indications I described in this talk on pediatric patients. The youngest I've scanned is 4 months and above. The case that I discussed, that was on high-frequency oscillator. Most of the indication in the adults are pretty much same there. You have to be careful about quantitative criteria for velocities that are different and age-based, but otherwise the same application in adults can be applied in pediatrics. The next question is, do you use the same device for velocity measurement and ultrasound resonation? So that depends on the kind of machine you have. We have an imaging Doppler, which means that the same machine can perform a B mode ultrasound for cranial imaging, color Doppler imaging, as well as pulse Doppler imaging. So you can use the same device for measuring velocities as well as B mode. But if you have a non-imaging Doppler, then your pulse Doppler waveforms are the only things that you can obtain from them for your scanning. The next question I see is, do you see intensivist learning point of care transcranial Dopplers? I think if you practice point of care ultrasound in other modalities and believe in the use of echocardiography, lung ultrasound as something that intensivists should learn, for the same reason, you should know and get yourself trained in TCDs. Again, this is a personal opinion. If you have phenomenal sonographers available 24/7 to provide you the kind of information that helps you take better care of patients, you may not have to need it, but that depends on your local infrastructure and the support available. The next question I see is, what is the most important finding on TCD exam for ECMO patients? So I think there are 3 different key ways in which you can use transcranial Doppler in ECMO patients. You have to distinguish whether they are VA ECMO patients, which is basically bypassing the heart with a constant pump that is not pulsatile. So you'll have a flat waveform compared to patients who are on VV ECMO, where they are only bypassing the lung for hypoxia. And the waveforms that you will find on TCDs will be pretty much the same as waveforms you see in a non-ECMO patient, with the distinct waveform shapes that we discussed. In both these patients, you can use TCDs to first demonstrate that the patient has kind of a normative range of positive CPPs. And if you don't have a radiological image to go with it, or the CT scan in the last day or 2 was unremarkable for any big mass effect or effacement of cisterns, you can use this as ongoing evidence to say that there is no global impairment of CPP enough for people to focus their neuroprognostication as the reason to decide not to pursue care. That's probably where I use it very often. The second place where you can use it is for what we call as HITS, or embolic phenomena. Patients on both kinds of ECMO can have issues in their circuit or the aerators, which can be a source of both air emboli as well as thrombotic issues related to anticoagulation, and have thrombotic emboli. And these emboli can be seen on a transcranial Doppler, and the occurrence of hits on transcranial Dopplers has been shown to correlate with cognitive outcomes and DWI lesions later on in these patients. So you can use the presence of hits to advise the perfusionist that there is a source of emboli in the circuit that needs to be addressed, or patient anticoagulation levels need to be checked. And that's a useful phenomena. The third place where TCDs are useful in ECMO patients is look for reperfusion as well as hyperperfusion markers as a serial phenomena rather than a one-time phenomena, especially if the patients have pre-existing focal lesions. So a patient had a known right MCA stenosis, and the baseline TCDs, fortunately known prior to patient being on ECMO, showed a very distinct asymmetry between the right MCA and the left MCA. And when linearly followed, we were able to find a perfusion circuit parameter that allowed us to maintain right MCA velocity comparative to their normal velocities prior to the ECMO. So titrating your ECMO parameters, the CO2 that is allowed versus the flow parameters is something you can titrate when you use TCD parameters in conjunction with your perfusionist. So that was the TCD use in ECMO. The next question I have is, wow, there's a flurry of questions. Your experiences with TCDs in STA-MCA bypass and predicting the risk of short-term stroke. So that's a great question. This is more of an outpatient indication rather than a true inpatient indication. We use TCDs both for selecting patients for STA-MCA bypass. There's especially something called vasomotor reactivity studies, as well as looking at the patency of the grafts and the development of the collateral circulation to supply the intracranial circulation using the same vasomotor reactivity post. and whether it predicts the risk of short-term stroke or not in the immediate post-op period, I'm not quite sure. I'm aware of any literature to that effect, but on a longitudinal serial basis, we definitely use vasomotor reactivity to follow on the patency of the STMCA bypass. Another question is about TCD applications in aneurysms and AVMs. So unfortunately, extensive literature in 1990s demonstrated that TCD quite didn't help in either diagnosis, follow-up, or rule out for aneurysms and AVMs, although you can distinctly show hemodynamic phenomena related to it. We do use TCDs in a lot of post-aneurysm coiling and clipping patients, mostly from the perspective of looking for embolic phenomena. So in patients that have coil protrusions related to patients' aneurysm anatomy, sometimes aspirin or heparin is required to prevent further thrombotic phenomena. And presence of hits on the TCDs performed post-coiling can sometimes help us guide whether the antithrombotic can be escalated from antiplatelets to anticoagulation, or even the degree of anticoagulation from low-dose, high-risk heparin protocols to higher heparin protocols, or even a combination of heparin as well as antithrombotics. So that's how we use emboli monitoring in TCDs post-aneurysms to guide management. And obviously, vasospasm management is something that's pretty well established and discussed. And the next question I see is, what are the resources available to get training in performing TCDs? There are a decent amount of resources available. There are in-person, hands-on training programs across the country, both on the West Coast and the East Coast, in the LA area, in the Seattle area, as well as in Winston-Salem. Couple of national meetings, especially the Neurocritical Care Society meeting, has been conducting a TCD course as a part of the pre-Congress session. Same for American Society of Neuroimaging meeting, where you can get hands-on training in TCDs. There are a few online resources available. So plenty of resources if you are interested in getting trained in transcranial Doppler. Any other questions?
Well, if no more questions, Artie, thank you so much for a wonderful webinar. And I just want to let everybody know that this will be recorded and it should be available on our website next week.
Well, I appreciate the opportunity and really appreciate everybody giving us an hour of their time to join us here.
Again, thank you, Artie, and thank all of our listeners. Some are actually in Europe late at night. Appreciate you tuning in. So thank you, and we'll see you at the next webinar.